So at this point, I have the privilege of turning the microphone over to Beth Finley Oliver. You know, Beth, I don't know if you've heard me say this before. I often say it, that the day I got accepted to medical school, my father gave me two pieces of advice. He said, because my father was a physician, and as is my mother, and he said, Joe, two things I want you to know. That's all I'm going to tell you. Number one, God made you with 2 ears and 1 mouth for a reason. He said, make sure you listen to your patients. Now, as I often say, he was a urologist. I don't know, I'm sure how much they listen when they're down there, but he was a listener. And number two, and this was long before it was, we talked about multidisciplinary care. He said, treat nurses like the professionals they are. And so we know that in our work, it's a team. Myeloma in particular is a team sport, and nurses play such a critical role in that team sport. So Beth is going to talk to us about communication, as we've mentioned that is a critical part of our care. So Beth, I'll turn it over to you. There is your clicker to move forward.
Sometimes I'm too short behind these, but let's see. Oh, you can see me.
Yep.
So it's so nice to see some people that I've actually invited here, and they showed up. Welcome, welcome. My name is Beth. I've been in the myeloma world for about 15 years. So me and Ken always joke, we're like the Moffateers, because I've been there 20 years. I won't age him and tell you how long he's been there. He's way over me. But, so yeah, I think nursing, our job's very important. You got to communicate, that's our job. We want to help you. The guys pick the regimen. My job is to manage the side effects and also to educate. Because I think sometimes when you see them, you get overwhelmed. You're like, what did they say? That's my job. We re-explain it. So you need to empower yourself. As you can see, they went over some of the symptoms, but even if it's a symptom, what I always tell patients is the symptom that you don't know why it's there. You don't know what happened. Is it related to this? No, it's not related to myeloma. My job is for you to ask me, then I'll help you. I'll help determine if it's something that I'm worried about, if it's a side effect that I can control. And you can see the little road. We're in this together. I always tell patients this is a marathon. This is not a sprint. So we're going to be in it together. We're going to talk. We're going to talk to the doctors. That is all your doctors, because myeloma is a chronic illness. So we need to be with our cardiologists, our primary cares, our nephrologists. Very important for us to be all on the same page. And then as far as screening, I think they touched on that, especially with the PROMISE study. Yeah, we're trying to get that out there and trying to collect data to see why patients have this. What is our future with precursor conditions? And then educate your friends, your family. Oftentimes our patients don't look like your typical chemo patients. So they get frustrated because people are like, you don't look like a cancer patient, you have hair, you look good, you're still working. So it's important to educate the family, the caregivers. All right, so what does care consist of? There's supportive care therapies. A lot of times when patients are newly diagnosed, they come in and some elderly have a bunch of comorbidities, but most of us are like, I've never even been sick. Why do I have this? Then we throw 4, 5, 6 drugs at you and you're like, oh, just the regimen alone trying to figure out, well, why am I taking this antiviral? Does this go with the chemo? Do I have to take it every day? So there's a lot of different drugs that kind of go with the treatment that we call supportive care. And they help prevent things. A lot of our proteasome inhibitors, our immunotherapy, they can reactivate the chicken pox. They didn't have vaccines when we were a kid. So they can reactivate that. We put them on antivirals. So there is a method to our madness. We're not trying to torture you by putting all these drugs together, but they are supportive care. Sometimes with myeloma treatment, I always say the disease can't be worse, or the treatment can't be worse than the disease, right? So if you come in and you're one of those unlucky patients that have a lot of bone disease, have a renal failure, we're going to be a little more aggressive up front because we want to get the disease under control. So the first few cycles might be a little rough, but then we're very adamant you got to stay on the treatment, right? So if you're having a side effect, you got to tell me. Most of the time, I always say I have a trick around it. What side effect you have, there's a trick around it. I can help with it. In the beginning, I don't like to dose reduce, but as some of my patients might know, steroids. I usually duck when I talk about steroids. I'm afraid people start throwing stuff at me. But we know they have a ton of side effects. Not everybody has all the side effects, which always kind of surprises me. But the idea is we got to do continuous therapy. I need to keep you on the medication. So talk to me about side effects. Let's see if I got the right button. I did. Oh, know your team. Look at Brandon over there, the myeloma specialist. Beautiful picture. That's my mugshot down there. But we're all a team. We're all caregivers. We've got caregivers, we've got patients, we've got family. We're one big happy family. And don't forget about our specialists, nephrology, cardiology. I don't mind refilling a med for about 30 days, but I really want you to go back to that cardiologist to make sure we don't need something else. So it's important to kind of keep them together. Hold on. There we go. So that's that big empowered. We want to share information. Come to an agreement, you know. I like to know what your quality life means to you. Not what I think quality of life is, but what you guys think it is. What's important to you? It kind of helps with the regimens going forward. You know, I've got patients, Alaskan cruise was very popular last year. Everybody was going on the Alaskan cruise. So at that time, maybe they didn't want, you know, IV injection treatments. I will say most of the time they are combined, but we do take what you guys want in consideration when we're thinking about treatment. Revisit decisions, yeah, and this is important, like clinical trials. Obviously, we're research. The only way we get medicine approved is by clinical trials. Clinical trials aren't something, you know, that whole guinea pig thing in the background, that doesn't exist anymore. You are your advocate. You tell us what's going on. We can always revisit whatever regimen we're on. If it's not working out for you, there's too many side effects, and we got to fix it. And it may sound like I'm concerned with treatment will impact my ability to care for my family. I do hear that because we do have younger patients that are still working, that still have kids. That's important. So we always want to take that into consideration. And we have little guides at IMF about important questions you can ask. It's just kind of a tool. Unfortunately, I can't read what is on that from this area, but I'm sure it'll be given to you guys. But it's a good questionnaire for you guys to answer and then maybe discuss it with your physicians and tell them, because again, what I think quality of life is not maybe what your idea of quality life is. So it's important to talk to us. Oh, and there's that tool that's on there. I think I can actually read that. So it's important to understand treatment plan, and that I feel is an overwhelming appointment when physicians kind of go over, okay, we're going to do proteasome inhibitors with, you know, IMiDs, the Revlimid, the Velcade, this is the schedule, and then you guys, they walk out of the room and they're like, when do I come back? So discuss with us. That's our job, to kind of help you figure out why you're taking this therapy, what's the schedule, what does it look like in the future. So there's important questions on there that the IMF, the Nursing Leadership Board, actually came up with this tool to kind of help patients with discussions with their providers. Some important tips. Again, I kind of harped on this, quality of life. I'm a big quality of life person. When a disease is not curable, it's just not fair for you, even though we say, yes, you know, you're in maintenance, this side effect can happen. That doesn't mean you live with it. You have to talk to us. The only way we know you're having these side effects is by you telling us. So don't be afraid with it. Sometimes patients are too afraid to say because we might dose reduce the medication. They're scared that that won't control the disease. We will tell you, we're not going to do anything to harm the disease process, but we want to keep you on the therapy. Take notes. And I actually always tell patients, write down your questions when you go see the doctor. I have a tendency to steal the patients. I always say that. I'm like, you don't need to see him. He's too busy. Talk to me about it. But you do have to see the physicians. But write down your questions. And what's funny is I went to a doctor recently, a GI doctor, had all these questions. I'm like, well, I'll remember them. I know what I'm doing. Forgot every single one of them. Literally, and this is what I do for a living, so kind of felt bad on that. And then afterwards, so during, you want to take notes, you want to ask for time, consideration, especially when we think of new therapy. Very rarely do we have to start the same day. Now, if someone has bad disease, that means, they have high calcium, lots of bone involvement, kidney, we might not have too much time to really, take it home, and we might start therapy that same day. But in general, myeloma is a chronic illness. You have time to think about it. With clinical trials, we don't ever take an answer the same day. Go think about it, talk to your family. Is it something that you can provide? Because trials are good and bad. We cross all the I's, all the T's with research. That means there might be some appointments that are extra. Clinical trials on the other side is bad because we cross all the I's and dot the T's, and you have to come in. So it's very scrutinized, and not everybody can do that if they're working. So just kind of think about what's important to you and what works with your lifestyle. And then, of course, we always want to continue to learn. There's so much information now with myeloma. I'm obviously partial to the IMF, so I always give out their information. But the website is full of information. You'll get some stuff out here. There's lots of support groups out there. I just heard about this group in the back with the outreach, so I will be getting with you on that too. So lots of stuff out there. Find a support group. And I can always tell when patients go to a support group. They come back in, they're like, why is he on 5 and I'm on 15? I know you've been to a support group. There's reasons, guys, okay? But I will be more than happy to kind of explain. So I think support groups are great because you don't feel like you're the only one, too. But be careful because you're going to hear the good, the bad, the ugly with it. All right, what do we communicate? I think it's important to always kind of look back in the history. I always say that myeloma is not hereditary, but I recently met a patient that had his dad and uncle that had myeloma, and I had no explanation for it. So we do know it can be in the family history, but it's not necessarily hereditary. And then, of course, the test results. Those are a little hard to read. If you look at our lab work when we first come in, and like he said, there was, 21 tubes. They always know when you're seeing a myeloma doctor at Moffitt. There's 14, 15 tubes. Don't worry, we give the blood back if you need it. But yeah, ask us, what does it mean? Again, when someone's newly diagnosed, they come to me, they're still kind of learning what to follow. I do the best I can with explanations, but learn what your myeloma is. And I actually had someone tell me, do you use multiple or do you just say myeloma? So I tend to say just myeloma because when I ask a patient, well, what type of myeloma do you have? And they go multiple. And I'm like, is it an IgA myeloma? Are you a light chain myeloma? It's important to figure out what tumor marker that you need to follow. And people learn over time. So I definitely think we're getting very good with education on labs and tests. And again, share your priorities, your goals. I often laugh because I work with Rashid Baz, another myeloma doctor, and he'll recommend usually a couple different therapies. And the patient's like, no, I'm not doing what you recommend. I want to do this one because, again, I got to go on the Alaskan cruise in a couple of months, and I want oral therapies. So it's good to communicate what your goals are with treatments. And don't ignore or self-medicate for pain. Yes, symptom of disease. So all the over-counter pain medicine, which are fantastic, I am a guilty person of ibuprofen, we don't like that. Those medications decrease the blood flow to the kidneys. As you've heard, myeloma's hard on the kidneys, right? I don't want two things working against your kidneys. Talk to us about pain. Don't just live with it. All the symptoms you don't live with, you communicate it to us. Pain especially, because if you're in pain, you don't move. And you're like, no, if I sit right here, I don't have to take any medications. Well, guess what? Infections, blood clots, other things happen. So I'd rather you talk about us, get the pain under control, and get you moving. All right, avoid the emergency room. Oh, yeah. Yeah, I'm not a fan of the emergency room, but sometimes it's needed. But again, always call your doctor. We'll let you know that, you know what, you're an hour from Moffitt. I can't afford you driving all the way. You have to go to the ER. in general, if you're close to your doctor, they'll kind of help recommend on where you should go. And side effects of medications. Yes, I've harped on that enough because I want you to talk to me about them. All right. So myeloma treatments both contribute to how you feel. When the disease is kind of taken off, that's oftentimes where we see people losing weight. Families kind of harp on them. They're not eating. They don't feel good. They don't want to eat. You have to eat. It's like food is like medicine at a certain point in time. But it's important that, you let us know. Fatigue's a hard one. I'm tired. We're all tired. Add chemo on top of that. Add myeloma. Add the stressor going on. It's a lot for you guys. It really is. But that's when we need to get moving. Neuropathy, my arch nemesis of side effects. We know what causes it sometimes. Sometimes the disease causes it. What I want you to do is just talk to me. Numb, tingling, burning, shooting pains, achy pains, any of those feelings, talk to us. Sometimes we have to dose reduce certain medications to help with it. I don't like it getting too bad because we do not have one medication that helps all neuropathy for patients. Sometimes the medications help, sometimes they don't. People have to live with it. So don't live with these side effects. Call and communicate with us. There's also the psychological appointment, anxiety. I always hear when the foot's gonna drop. Am I on my time? I'm sorry. Okay, let me keep going. Okay, so yeah, anxiety, depression. There's a real reason. You have a cancer. It's not controllable, or it's controllable, but it's chronic. So sometimes we do little antidepressants to help. We can get you off of it. Financial, this is a huge one. Our drugs are very expensive. There are copay assistance programs out there. You have to talk to us. Nobody likes discussing their financial situation, but we can help. There's lots and lots of copay assistance out there. All right, example, GI definitely happens. A lot of our treatments can cause loose stools, the IMiDs. I've got a trick around it. Fiber, Imodium, cholerestamine sometimes helps. Always want to increase fluid. This is not wine and coffee. Fluid is hydration, so water. There is antidiarrheal medication. If you're losing a lot of fluids one way, you need to make sure you're doing it oral. If you can't, call us. We can do some fluids for you. Fatigue, anxiety, depression, these are all real. It's expected. You're going through a lot. But again, we can help. There are resources out there. I'm trying to hurry because I know we got break coming up and everybody wants their coffee. So there, again, the financial burden, co-pays, prescription drugs. I don't know if they're ever going to go cheaper. Every time I hear something went generic, I got excited. Then I heard it was $700 cheaper. I wasn't excited. But there is help out there. You just got to ask. So in summary, can and should you be a part of your healthcare? Absolutely. You are your own advocate. So there's lots of patient portals out there with all of the information on there. Pull it off. I think the medical community is the only one still faxing information. Pull it off online. Take it to your local community doctor. And together with us, we can all navigate this disease process. Let me see, and many, many, many resources out there. I'm always partial to the IMF. We give, and lots of it's free. They have a number. You can call them, and they'll give out, send it to your house, no cost to you.